Hello, this is Christian Perring, and I am going to be giving you a sort of narration on this presentation. And the topic of the presentation is healthcare providers' responsibilities to their profession. There's 32 slides, and I'll be going through them fairly swiftly. So if we're going to be talking about professional responsibilities, then we need to have some idea of what a profession is. Not surprisingly, this turns out to be pretty hard to define in any precise way. We have a rough idea because we have examples of what we think are professions. Uh, Obviously, there are doctors and lawyers. They're the sort of classic examples of professionals. But then, what about other jobs? What counts as a profession? So, we might think about accountants or engineers, actors, and teachers. Do they count as professionals? Well, it seems like in some ways they do, um, but maybe they don't have all the features that you see with doctors and lawyers. So it's going to be there's going to be a lot of gray area around what counts as a profession and what doesn't. The obvious things to point out is a profession requires training in order to become a part of the profession, various sorts of getting information, but also maybe learning the kind of ways that the profession behaves and the expected norms, stuff like that. Uh, and also, there's the idea of there being answerability to the professional organizations, so that you have to kind of be part of a community, something like that. With healthcare, there's obvious professional associations in the USA, groups like the American Medical Association, the American Pharmacists Association, the American Nurses Association, the American Psychiatric Association, and so on. There's often groups for each sort of subdivision within medicine and healthcare. And also, it turns out there are sometimes more than one group uh, representing certain groups. So then there's a question about, well, is one the official group and the other unofficial? Do they both have claims? So there's questions about to what extent a professional group is the main one, and that has to kind of be relevant when thinking about which group represents the profession. If the idea of a professional association is that it somehow governs the profession, then we want to know to what extent does it have power over the profession? Can it expel people from the profession? Or can it put requirements on people for what they have to do? And obviously, in theory, that might be possible, but it turns out that certainly a lot of professions, and certainly in a lot of healthcare professionals are not required to belong to a professional association. Doctors do not have to belong to the American Medical Association. Psychiatrists do not have to belong to the American Psychiatric Association, and many don't. So in what sense do they have power over people who aren't even members of those associations? Clearly, there may be attractions for people to belong to the associations. Often, those associations promote or kind of regulate continuing education credits, which professionals need to have. Uh, but it turns out often that's a lot to do with state regulations that setting out what credentials professionals need to remain certified and licensed. So it's it may be that the professional associations don't actually have that much power. So as I'm saying, it's licensure, which is actually pretty important, and licensure is often regulated by the state, or tends to be regulated by the state, and so it varies from state to state. So thinking about New York State, uh, the state requires for pharmacists that they be of good moral character, they be at least 21 years of age, and then they meet a list of education, examination, and experience requirements. Uh, so, those are the kind of things which the state which often sets out these requirements for licensure. So then it becomes a borderline between a professional requirement and a legal requirement, and maybe an overlap between those two things. Obviously, the law has to do what the law has to do, uh, but that doesn't necessarily tell us about moral obligations. And we are mainly interested in issues of morality here. Uh, so we might think about professions in a profession in another way as a community of peers. And so if you're going to be part of a community, then you have to play your role in the community to sustain the community. It's not just a bunch of people. Uh, there's some sort of extra identity to the community, which you don't get just from having a list of people. So I think that's a pretty important idea for the idea of a profession. Um, and so if you're part of a community, then you have a moral obligation to keep that community going. Now, in healthcare, uh, we can think about this idea of professional obligations and how they are different from just regular obligations to patients. In medical ethics, we talk a lot about the obligations to patients, and there are all sorts of principles involved in thinking about those things. But the idea of professional obligations seems to be over and above those obligations to patients. So there's the idea that professionals have to think about the good of the profession as a whole, not just the interests for themselves, and not just the obligations to patients. So that helps to explain something like why healthcare professionals and pharmacists have to be of good moral standing because they're representing their profession and their behavior should not reflect badly on the profession. So to get specific about this idea of professional obligations, we're going to look at three different kinds of cases. There's whistleblowing or ratting on colleagues, when colleagues or possibly a whole organization is doing something reprehensible. Then there's the question of what sorts of opinions should people be able to express openly in public and especially on social media, and when should it get them into trouble as healthcare professionals, and when should it even lead to them losing their jobs. And then finally, we're going to look at conscientious objection to particular procedures, when doctors especially don't agree with the morality of a particular procedure that a patient wants them to do. Okay, so the classic example would be abortion, or now these days, including requests for the doctor to help the patient die. If the doctor has a moral objection to that, to what extent should the doctor do it anyway because of their status as a professional? So those are the things we're going to be looking at. Whistleblowing is a big issue in a great deal of business ethics, and it quite often happens that workers see stuff going on in their place of business, and they know that it's not right, and they have to make a decision about are they going to report it. And if they do report it, obviously they are going to be placing themselves at risk for retaliation, and they may even find it difficult to get a job elsewhere if they have a reputation as being a whistleblower. So it's it's certainly a difficult decision. Now we might say, well, it may be psychologically or personally difficult, but still people have an obligation to do it. But there is a question about to what extent people do have an obligation to do it, and to what extent it is balanced by other sorts of moral considerations. Certainly, if you look at the main policy documents of official professional bodies, they say that healthcare professionals should report their peers when those peers are incompetent or they behave unethically. And in particular, they should report it to authorities or the licensing board. It may be a bit unclear about exactly what has to be done and when reporting has to be done. So, for example, with pharmacists, it may not be so clear that they have a duty to report incompetent behavior of doctors to licensing bodies. So, because there's pharmacists and there's physicians, and they have different degrees. So there might be a question about, is it really the pharmacist's job to report a doctor for incompetence? But there's going to be a whole variety of cases. We might also think about the responsibilities of nurses when it comes to reporting other healthcare professionals, and the people might be hesitant to say, oh yeah, nurses should definitely be reporting doctors for incompetent behavior, because you might worry that nurses have less training than doctors and so can't really tell when behavior is incompetent. Although that's not so clear when it comes to unethical behavior. It seems like expertise about what counts as unethical is going to be kind of just a general expertise. You can see if somebody is, for example, sexually assaulting a patient, right? So you don't necessarily need to have a lot of expertise in order to report that. So there's going to be some gray areas, but there is this general policy that healthcare professionals should report their peers when appropriate. It turns out that in real life, often people are very reluctant to report their colleagues. And most obviously, you see this with cops. Cops stand by each other to a large extent, and it's pretty rare for a cop to rat out their colleagues. And similarly with prison officers. Now you might say, well, being a cop isn't a profession. I'm not going to kind of debate that one. But certainly, even in cases which are clearly professions, there's a lot of reluctance for people on the part of people to rat out their friends or even their colleagues, and partly, that exactly why that is needs to be investigated. It may be some sense of loyalty to other people, or it may be a sense that it's not their job, and there's been some investigation of that, which we'll look at. Here are some statistics from one study. You can look it up on the title. Many physicians don't want to rat on each other. published in Fierce Healthcare, and presumably there's going to be a reference there to the original study. So apparently in the study it was found that 17% of doctors reported knowing of a colleague who was impaired or incompetent. And that seems a fairly significant number. And apparently 2/3 of them did report, but 1/3 did not. I'm sort of impressed that 2/3 did report. It seems to be quite a high number, and I almost wonder whether that is actually a typical proportion of people ratting out their colleagues. So the people who, and I guess there's also this tendency when you're answering a survey, you want to look good or you want to give the impression you did the right thing. So people may over-report their tendency to do the right thing and under-report their tendency to do the wrong thing. So that might be a reason why it's an overestimate of how many people did actually report. In terms of the reasons people give, there's fairly easily understandable reasons. So 19% believe that somebody else is going to do something about the problem. 15% said that there was no point reporting it because nothing would happen. 12% didn't report because they feared retribution. 10% said that it just wasn't their job to rat out their colleague. And 9% feared that if they did rat out their colleague, then that colleague would be punished too severely. So they felt like in a bind. So those are sort of interesting reasons that people have for refusing to whistleblow. I think it's worth emphasizing that there's a lot of everyday kind of sentiment that it's kind of wrong to rat people out, unless it's very extreme circumstances. So there's this idea of retribution, the snitches get stitches, but there's also this idea that people should be loyal to their colleagues and be understanding that people may be going through a difficult time and just hope the problem is going to be temporary and go away. So there is a great deal of reluctance to report cases of incompetence and wrongdoing. And that shouldn't be underestimated. Whatever whatever it says in kind of the books about professional obligations, people are going to be reluctant to kind of report colleagues a lot of the time. So what's the moral issues? Well, certainly, we can definitely agree in extreme cases that people should be reported. If they're abusing patients, if they are killing their patients, if they are, well, probably if they are committing fraud with their patients, people would say, oh yeah, that's serious enough that they should definitely be reported. But there's going to be all sorts of other areas where we don't think it's quite that serious, and we might also say that you have a duty to your friends and your peers to give them a chance. So it may not just be one moral consideration. You might think you have to balance at least two. You have colleagues and you should respect your colleagues and maybe give them the benefit of the doubt. So we might say, it's pretty fair to occasionally wait a bit, see what happens, see if the problem continues, and then if it really doesn't improve, then you make a report, but you don't just do it too quickly. So definitely we would think that the more at stake, the greater the duty to report, but in other areas there's going to be a lot of gray area. Another moral issue that's part of this is that we should, we can agree that it's wrong to punish the whistleblowers. If somebody is acting out of conscience and they're saying that my colleague is incompetent or is doing something morally wrong, then the person doing the reporting shouldn't be punished for doing the reporting. And certainly there are plenty of laws to protect whistleblowers. Now, it's one thing to have a law protecting people. That doesn't necessarily mean that it's easy for them to actually avoid bad consequences of whistleblowing, because it takes a lot of effort to hire a lawyer and kind of make sure that you're getting protection, to kind of sue people for wrongful termination of employment or lack of promotion. So it can be, just because there's a law doesn't mean the person's actually protected, but at least there's some possibility of protection there. And we can agree that it's wrong to punish the whistleblowers. And to wrap this up, here's the New York whistleblower law, which is part of the labor law, which prohibits employers from retaliating against employees who report violations of the law. And that includes reporting health care fraud. And it also prohibits retaliation against employees who disclose or threaten to disclose an unlawful activity, policy, or practice that creates a substantial danger to public health or safety. And in 2022, the whistleblower law was expanded in various ways. And there's also a False Claims Act that covers a range of fraud types, including healthcare fraud. If a whistleblower proceeds with a case on their own, they may receive between 25 and 30% of their recovery if the state does not intervene. So New York definitely has a law protecting whistleblowers and even rewarding them in some ways. Now we move on to the second of our three kinds of cases, looking at the professional responsibilities of healthcare workers. And this one is on expressing personal opinions on social media. And this is definitely a big issue. You can find all sorts of cases if you just Google the question of kind of healthcare workers and social media. So quite recently, two NYU physicians were suspended for posting their support of Gaza and against making comments against Israel, and they were suspended. I think they were accused of being anti-Semitic. There's a kind of, you can find all sorts of lists of tweets that will get a doctor in trouble. In the UK, National Health Service workers have been disciplined for inappropriate social media use. And in particular, in the UK, there's been controversy about healthcare workers posting about trans issues. So if they post something which is interpreted as being anti-trans, then they can be disciplined. So there's also, as I'm saying, you get a lot of these issues because obviously people are using social media and other people are sort of tracking them down and reporting them. So it's something that's happening a lot. The moral issues are pretty simple here, really. There's a simple dichotomy between the idea that people have a right to say what they want. This is a free country, and so people should be able to express their political opinions and their other opinions, even if they are unpopular. On the other hand, there are professional responsibilities, and they involve not bringing the profession into disrepute. So, these are kind of pretty big issues, and they are kind of hard to navigate, really. It seems like often it's a kind of power battle, and exactly working out where to draw the line is pretty tricky. Okay. Here are some examples from nursing about nurses who have got into trouble. So one was a nurse who took a picture of a man getting an electrocardiogram and posted it on Facebook. And apparently, there's no particular expressing of opinions about it, but still the person got into trouble because maybe a violation of privacy, even though they didn't post the person's name. There was, interestingly, not a social media case, but just one nurse texting another nurse and a physician describing a sick child and his mother in an unfavorable light. So the nurse was making kind of negative comments about patients in texts, and that was enough to get the nurse into trouble. And then a fairly clear-cut case of staff members at a long-term care facility who videotaped and photographed a colleague who was in labor, and they mocked the woman, posting photos of kind of questionable taste on various media sites, and it seems like, well, that's so that's not involving. I guess it is involving a patient because the colleague was a patient at the time, but it's talking about other colleagues, and that was seen as a big problem. So here we have a list aimed at nurses about what behavior to avoid, especially in regards to social media, but also just generally what kind of behavior they should avoid. So negative comments about the workplace, complaints about co-workers and employers, threatening or harassing comments, that seems like pretty obvious, you shouldn't be doing that. Photos or comments about alcohol or drug use, domestic violence, even arguing with a spouse, use of profanity, it seems really, I mean, that you can't even swear, and then sexually explicit comments or racially derogatory comments. It seems, we might say, well, obviously you can't make racist comments, but you can't just like talk about sex. That seems kind of puritanical. So we might kind of worry that these professional standards are kind of maybe sometimes too strict, and we might want to defend freedom of expression. But certainly these things are worth being very careful about. Finally, we look at the third example of professional standards, and in some ways this is the most kind of philosophically interesting of the three. It's about when doctors, but maybe also other healthcare professionals, have objections to particular procedures, and questions about when they should be allowed to opt out, and if they do refuse to engage in a treatment, then what other steps should they take with the patient to help the patient along. So various kinds of example that come up with this is medical aid in dying. In Canada now, this is a pretty standard treatment. Patients can request help. If they want to die, and if they're competent, then the state will provide a doctor to help the patient die. And it's also true in various other countries and various states in the US. There's lots of details about that. And there are some doctors who say they do not want to do that for moral reasons. Obviously, abortion is very controversial. Some doctors don't agree with abortion, and I guess it may depend on the particular kind of case. If an abortion is going to save somebody's life, is going to save their mother's life, then that is a fairly strong justification of abortion. More controversial cases may be when the pregnant woman does not want to have a baby because it's inconvenient or it's not appropriate. She doesn't judge it to be appropriate for her at that stage in her life. There's cases of in vitro fertilization, and to what extent doctors should be involved in that. That's become increasingly controversial in the last couple of weeks due to connections with the abortion debate. And then an issue which has become very controversial in the last few years has been gender-affirming treatment for young people. And so some doctors may not want to be involved in that. Now, the standard approach is that if a doctor does not want to perform a treatment, then they still have an obligation to refer the patient to a different doctor who will do the treatment. So the idea is the doctor can have clean hands in the sense of they're not the one doing the thing they disapprove of, but the patient still gets what they want. Now, some ethicists have argued that that is unsatisfactory for some doctors. For example, if a doctor does not believe in abortion and maybe believes that abortion is equivalent to murder, then they're not going to be happy about kind of helping the patient get an abortion in any way. And so they're not going to want to refer the patient to another doctor who will perform the procedure. So there's some debate about whether physicians should always refer patients to somebody else. And if they don't, then they could just say, look, I'm not doing anything for you, and that's it. And so providing no help whatsoever, leaving the patient just work it out for themselves. Now, one important thing in this debate is that it may be fairly straightforward to refer a patient to another doctor in a big city because there are lots of doctors. Although it's not always that straightforward because there are often long waiting lists and doctors and patients may be needing the procedure quickly. But it certainly becomes a more difficult issue in some rural areas or areas where there's a low population of doctors. If there's just one doctor or one specialist in the local vicinity, then telling the patient to go elsewhere may just not be very feasible for the patient. And it may leave the patient with basically no options. So the effect of a doctor refusing treatment may actually be quite severe in some cases because referral is just not possible. So let's think about the ethical issues here. And let's start off with the argument for conscientious refusal to treat. And it seems pretty straightforward. The idea is the doctor has their own moral code. Sometimes that's going to be tied to their religious beliefs, but it doesn't necessarily have to be. But certainly we have a strong belief in the freedom of religion, so we can understand how we will be uncomfortable with making somebody do something which is incompatible with their religious beliefs. And certainly we think it seems fairly easy to understand how while some procedures may be pretty standard, abortion has been pretty standard in the US for a long time. In vitro fertilization is standard. And I guess with medical aid in dying, maybe it's less standard, but in some places it's becoming more standard. And we're going to talk about the levels of what counts as being a standard treatment. But I guess my point here is that it's okay for a doctor to disagree with some wider social values and to say that they think that a standard treatment is wrong. So on the basic idea that people have a right to control their own lives and control what they do, we would then say that the doctor has a right to refuse to treat a patient in some cases. So their personal moral code trumps the obligations to the patient or to the profession. That would be the argument for conscientious refusal. And here's a list of standard cases when doctors can refuse treatment. Now, not all of these are to do with differences in morality. They can be for other reasons, but it helps to clarify the debate to think about these, I think, 8 conditions. So number 1 is the medical treatment is unlikely to achieve or help achieve the goals of care. So in a standard sort of case is when a patient comes in with a viral infection and asks for an antibiotic, then the doctor can say no because it's not going to do any good. The second one is the physician is not knowledgeable enough to provide the relevant treatment. So if it's a specialist treatment and the doctor isn't a specialist in that area, then the doctor can say, no, I can't do it. Third one is providing the treatment would cause unacceptable risk. And that seems, obviously we might have some debate about what counts as acceptable or unacceptable. Presumably there are some clear cases, and we would want to say that certainly a doctor can refuse a treatment if they think it's too risky. That makes a lot of sense. Then the fourth one, the treatment violates medically acceptable practice. So yeah, if a treatment is considered kind of non-standard, then it seems fine for a doctor to refuse to do it. Although it's worth noting that, say with prescribing medication, a lot of medications are prescribed off-label, meaning that they are prescribed for things that the medication was not originally approved for. So then there's a big gray area of what we mean by what counts as standard treatment. And in some cases, the professional association may have spelled out what standard treatment is, but in a lot of cases, they probably won't have spelled it out. So there's going to be a lot of gray area about what counts as medically acceptable or medically standard. Then moving on to the moral issues. The fifth one is providing the treatment would violate the professional the professional moral integrity of the physician. And that's contrasted with the sixth one, providing the treatment would violate the personal moral integrity of the physician. So there's a kind of a distinction there about what do we mean by the professional moral integrity and the personal moral integrity. I think the cases I've been talking about so far have been about violating personal moral integrity. Uh, the professional moral integrity would be violating the moral standards of the profession. It seems that would be, it's going to be unusual. It's going to be hard to think of a case which is medically standard and yet violates the professional moral integrity of the physician. So that fifth one doesn't seem to be such a pressing case because it's sort of it's already covered by the fourth one. So the one we're really thinking about here is what violates the personal moral integrity of the physician, and that as we've talked about already, what cases will come up with cases of doctors who are against abortion or against physician-assisted suicide, and so they say they don't want to participate in that. Then the seventh case is the outcomes of the treatment would violate the essential nature or inherent worth of the patient. So if it's basically very bad for the patient, and then there are all sorts of questions about that. There are some somewhat bizarre cases of patients with psychiatric disorders, body dysmorphic disorders, where they want to have their leg or arm amputated by a doctor when there's nothing wrong with the leg or the arm, but the patient views it as abhorrent to them. Somehow they really hate that part of their body. And doctors would say, well, that doesn't, again, that's probably not going to be a medically standard practice because it doesn't seem to be right to amputate a limb when there's nothing wrong with it. And also, it seems like it would be bad for the patient. You're going to make the patient disabled. So that comes up there. And then the final one is the treatment is morally repugnant, which seems a little bit stronger than simply violating the personal moral integrity of the physician. It's the idea that there's something objectively morally repugnant. If it is objectively morally repugnant, it doesn't seem like it's going to be a medically accepted practice in the first place. So really, the major clause there is the one about the personal moral integrity of the physician. So now let's think about the argument against the physician's right to refuse treatment. And so the main idea is that the physician has a responsibility both to the patient and the profession. So the idea is the patient needs a treatment, and the physician is the one who can provide the treatment. They have a relationship. The physician is the patient's physician. And so the patient should get the treatment that the patient medically needs. And then there's the idea of the duty to the profession, that a physician has to represent the profession, and the profession provides certain sorts of treatments as standard, and so it would be inappropriate for a physician to opt out of that, because that's basically opting out of the profession. And so certainly some people make that argument. They say that professional obligations are demanding, and any member of a profession has to carry out standard professional obligations. Certainly it's an interesting argument, although when you're thinking about cases of abortion or maybe even in vitro fertilization or physician-assisted death, we might wonder whether they make a lot of sense there. So it definitely requires further thought there. So some people would say that, arguing against a physician's right to refuse treatment, they say if the physician doesn't want to engage in those procedures, then they should choose a different profession, because those are the procedures which are part of what it is to be a member of that profession. Other people think, well, no, you should be able to kind of opt out and just refer to another patient. Sorry, no, you should be able to refer the patient to another physician. But they still want to say that the doctor's morality doesn't always have to come first. There can be cases where if the doctor has a responsibility to vulnerable patients. The patients need help, and it's a kind of a luxury for the doctor to be indulging their own moral conscience when the patient needs help. So the idea is that the patient's values trump the doctor's values, and the professional standards trump the doctor's values. So those are the kind of arguments that go against the physician's right to refuse treatment. What do we want to say about this debate? I mean, in the US, we tend to be very individualistic. We tend to say that people should be able to follow their own conscience. But there have been various legal cases where it's been judged as discriminatory for people to refuse to treat people they don't agree with. And I guess this has come up especially in cases of trans and maybe gay people. That people can't just refuse to engage with people because they disagree with a lifestyle or something like that. So there is at least a balance there, a debate between this idea of individual morality and social standards. And then there's this idea of belonging to a profession. As I was saying right at the beginning of this presentation, exactly what it means to belong to a profession is not entirely clear. You can join a profession, but exactly what moral obligations that puts on you is certainly up for debate. So if you're going to really stick to this idea that doctors have professional obligations over and above any particular obligations to patients, then you have to be very clear about what a profession is, what the medical profession is, and exactly why belonging to the profession places moral obligations on its members. That well, that's not necessarily such an easy thing to do. And so I guess what I'm saying is that I find it pretty hard to kind of see how you can compel somebody to go against their own conscience. If in an individualistic society which places all this emphasis on personal choice. Maybe you can make a case that doctors have professional obligations to patients, but I'm still kind of wondering exactly how would you make that case. And then there's this big question about when are treatments standard? There's this idea that doctors have an obligation to practice standard treatments. But what about medical aid in dying? So it's legal in Canada, it's legal in the Netherlands, it's legal in Belgium, it's legal in various states, including New Jersey and Oregon and a growing number of states. So, is medical aid in dying a standard treatment? Well, it's also worth noting that it's illegal in many US states. It's illegal in the UK, and so it's a highly debated treatment. So it would be very odd to call medical aid in dying a standard treatment. Now we might also ask, what about prescribing puberty blockers to trans or non-binary children? Is that a standard treatment? Well, it has been recommended by various professional organizations, so to that extent it does seem like it's a standard treatment. On the other hand, there are lots of states saying that it's immoral and that they're trying to make it illegal. So there's big questions about whether or not it should be considered a standard treatment. Who gets to decide what counts as a standard treatment? Is it just the doctors themselves, the professional organization? Should there be a wider debate about it in society? So I think the idea of a standard treatment needs a lot of elaboration, and there are going to be a lot of gray areas there. Maybe some treatments are very standard, but the ones which are controversial are going to be almost by definition less standard, and or less easy to kind of say they're standard. So I think that certainly requires further discussion. Let's think about finally the case of abortion to save a mother's life. So there may be doctors who think that abortion is always morally wrong, that it's always morally wrong to end the life of a growing fetus, no matter what the consequences. We might consider that to be an extreme moral view, and we might disagree with it, but the question is, do doctors who believe that have a right to refuse treatment? Now, in a case where the mother or the pregnant woman will die if she doesn't receive the abortion, then it seems like there's going to be a lot of agreement among doctors that the best thing for the woman is to receive a abortion. So maybe there we could say, yeah, that's a standard treatment. And if not having an abortion would lead to the woman's death, then it seems like we have a pretty strong case to say that the physician has a professional obligation to save the life of the woman, even if that is going to mean the death of the fetus. I guess one thing to note is that in the scenario we're considering, the fetus would die anyway if the pregnant woman dies. So there's no option of saving the fetus. We're simply thinking about should the physician perform an abortion in order to save the life of the pregnant woman. And the doctors who refuse say like they refuse to be actively ending the life of a fetus, even if they know that the fetus will die anyway if the pregnant woman dies. So we might think, well, this is a pretty clear case that the physician should at least refer the woman to another person who will perform the abortion. And it would be wrong just to kind of refuse to have any role in that at all. So suppose that a doctor does refuse to engage in that, then to what extent should a professional organization, a medical organization, take action against a doctor if the doctor's refusal of treatment leads to significant harm or even death for a patient. So I mean, that's an especially difficult case and will help us kind of think about the moral issues that arise there. All right, now we're at the end. This is just wrapping up. And I hope that this presentation has led you to kind of think about some of the issues involved. Uh, I, I definitely think it's a pretty major area of medical ethics these days, because different healthcare professionals have all sorts of different moral beliefs, and we may disagree with those beliefs, but the fact is that they have those beliefs, and so we should, investigate this kind of topic more. Notably, sometimes it gets covered a little bit in the under the heading of physician autonomy, but I think it deserves a more full treatment, and I've tried to give a somewhat fuller treatment here. Definitely, it's going to be contentious. It's going to be highly controversial because some of the controversy about issues like medical aid in dying, about abortion, and about giving gender affirming care to trans kids, those are highly controversial cases. So the controversy is going to lend itself to the question of should doctors be able to refuse treatment. As we've seen, the whole question of what counts as a profession is something that's in need of investigation and elaboration, and is not as obvious as it might seem. And that definitely seems that this idea of professional obligation is something that could be very important, and especially if we're going to decide there are such things as professional obligations. All right, thanks very much.